Hello, everyone, and welcome to How to Address Challenging Behaviors. I'm Lynn Audette, a Family Service Coordinator here at the CDLS Foundation, and I'm excited to be hosting today. We also have Whitney Rinaldi from the Foundation on with us. She will be assisting with the question and answer portions of the presentation. Before I introduce our speaker, we would love to see where you are calling in from. On your control panel, you will see a Questions tab. Please type in the state or area that you are joining us from and the age of the person with CDLS in your life. While you are sending in your questions, I'm pleased to introduce today's presenter. Dr. Julia O'Connor is a clinical psychologist at the Kennedy Krieger Institute in Maryland. She is also a longtime member of the Foundation's Professional Development Committee and the CDLS Clinic in Baltimore. Before I hand the mic over to Dr. O'Connor, you will see a poll we would like for you to answer. While you are doing that, I have a few housekeeping items to cover. First, today's recorded webinar will be available after the live session and will be accessible on the CDLS Foundation website. Look for webinars under the Resource tab. During today's presentation, if you have a question for Julia, please send it through the Question tab. We'll be answering questions at a few different points during this webinar. And thanks so much for your response. I see that just about 96% of you have an individual in your life that has a behavior issue. Now, I would like to welcome our presenter, Dr. O'Connor.
Hello, welcome everyone. Try to get myself situated here. It's very nice to be with you this afternoon. And thank you, Lynn, for your kind introduction. As she mentioned, I've been working with individuals with CDLS through the Foundation for many years now, as well as being a psychologist for, a long time. So it's been quite a while, and I've been able to work with individuals with a lot of different types of behaviors over these years. It's a pleasure for me to be with you today to talk about CDLS and the challenging behaviors that you might face. So first, I wanted to give you an overview of what we're going to be covering today. We're going to just be touching the surface on all of these topics because there's so much information that I could provide to you. There's a lot available. So
Julia, I'm sorry to interrupt. Can you share your screen so we can see your presentation?
Oh, I thought it was. Hold on one quick second. Hold on. Where'd the little button go? Uh-oh. Okay. All right, Lynn or Whitney, which button am I missing? Up there, I didn't have that. Okay, now I've got that button. Okay, there we go. Sorry, let me backtrack a second because my slides. Okay. So here's an overview of what we're going to be presenting today. I'll be talking about some of the most common behavior challenges that we see in individuals with CDLS. And the next phase we'll talk about is what do we do about those problem behaviors, incorporating components of both, looking at what we do from an assessment standpoint as well as from a treatment standpoint. As I mentioned, there is a lot of information regarding problem behaviors with individuals with CDLS. So if we don't cover everything, certainly you're always able to reach out to the Foundation and they will direct your questions to me so that I can address them with you directly. Okay, so there are a few caveats that I want to mention, very important points about challenging behaviors, because they're different than what you might have happen when you go to your medical professional about other situations, such as a medical problem. So it's not just like a disease. With behaviors, there isn't just one common treatment path. The way that we address problem behaviors is to do a very thorough assessment first so that we can determine what we call the function of those behaviors in order to come up with the right treatment path. So it's not like going to the doctor and getting a shot or getting a pill and they will all be gone. We have a lot of assessment information to gather. Oftentimes I correlate this for families with when you go to the doctor just for a cold, you're going to get a very quick fix. But this is more than just a cold. This is ongoing behaviors that are happening that might be causing some significant challenges in the environment. So we need to do a more thorough assessment and go to that professional who has to do a lot of assessments, do blood work and x-rays and all sorts of different background assessments before they can come up with what the best treatment options are. So I look at challenging behaviors more from that, where the medical point where you have to do more assessment ahead of time so that you can come up with a treatment. We know that the causes of various behaviors can vary widely. So it's not just that simple to say this behavior of self-biting, oh, you always do this treatment, because it's not that way. I also have to mention that assessment does take time. And I know that's very challenging from a family's perspective when behaviors might be causing significant disruptive in the home environment or the school environment. But in order to get the right treatment, we have to make sure the assessment piece is very, very thorough. So once we have a really clear understanding of the possible functions of the behavior, we have a much better idea of what do we do next to intervene and develop a treatment. And then that treatment evaluation can take time. In my clinical work, oftentimes we'll start by having the treatment evaluated just with our staff before we ask the family to implement that treatment strategy. And that way we know that it's working for us, and then we'll teach you exactly how to do it. Other times we might need to have the family implement the treatment right from the get-go because maybe the behaviors don't happen with the other people. But that treatment evaluation does take some time to conduct. Now, some of the behaviors that we see in individuals with CDLS include some of the ones I have listed here. Self-injury, very common, compulsive behaviors or repetitive behaviors, similar to the types of behaviors you might see with someone diagnosed with obsessive compulsive disorder, and some of your individuals may actually be diagnosed with that. Or you may see behaviors that are related to an anxiety disorder, or you may see attention deficit disorder. So these are some common issues that we see. In particular, some of the self-injury has a wide range of topographies that might be elicited. These are just some of the different topographies I personally have seen in my work with individuals with CDLS. You may have others that your child particularly engages in, but these are the most common ones that I personally have seen, as well as those that have been identified in the literature. When it comes to self-injury, we're often asked, well, why do some kids develop this and others don't? Because we do see self-injurious behaviors across a wide range of individuals who have developmental disabilities. Some of the most common risk factors of developing self-injury are not only the level of developmental disability, but also the presence of a genetic disorder. Most common association is going to be a deficit in expressive communication. And that's probably very likely something you see with your child, that they're not able to effectively and consistently express their desires or their needs. And so that makes it very challenging. And self-injury might be one of the ways that they're able to let you know that they need something or they want something. So we found that in the research literature that degree of or severity of intellectual disability is a big factor, and that we see it 4 times greater in individuals with severe to profound intellectual disability than with mild to moderate disability. We see self-injurious behaviors 4 times more likely to happen in those individuals. Overall, the prevalence of different behavior challenges in CDLS varies, but overall, the research has shown that about 55.6% of individuals with CDLS across the age range do present with self-injury. This was conducted by Oliver and colleagues, and he is one of the most prolific researchers in the field working with children with CDLS who also have behavior problems. Approximately 32% of our individuals with CDLS also develop physical aggression, while about 41% may have some property destruction. The one factor that was surprising in the literature that Oliver and his studies have found is that the prevalence is not necessarily something they see increasing with age. While we do see oftentimes that puberty may elicit or be common across some of our individuals when they start to develop these behaviors, it is not necessarily the case that individuals always have more problem behaviors that increase with their age. Puberty is a time in individuals with CDLS that we see changes in behavior that are very common that happen also in individuals that don't have CDLS. So you see more irritability, more moodiness, and things like that. Change in sleep patterns might also take place. But what the researchers suggest with puberty is that it's very, very similar to what changes you see with your typical population. Other examples of some of the challenging behaviors that we see in individuals with CDLS, the aggressive behaviors that we see, including hitting, kicking, biting, property destruction, disruptive behaviors, yelling, banging, screaming. Now, pica is one of those behaviors that can be pretty dangerous. It's the ingestion of inedible items. The ingestion of the items makes it pica. Otherwise, it might just be mouthing, where the individual may just mouth on different objects or items. Elopement. Elopement is also commonly seen in individuals with ADHD, and sometimes our individual children with CDLS are comorbidly diagnosed with ADHD, and you may also see elopement where they're running off from the designated area where they're not being able to be supervised because they've run off. We also may see noncompliance, both active noncompliance or passive noncompliance. So that is just not following demands that are placed on them, as well as some incontinence or dangerous behaviors. One thing I didn't mention in here is sleep disorders. That is also something that happens quite often in individuals with CDLS. We're not going to speak a lot about sleep disorders today, but if that's an area that's challenging for you or your family, what I typically suggest with any type of sleep disturbance is to make sure there's no medical complications in terms of whether there's some sleep apnea that might be happening, because that might influence their sleep patterns. So those are the different types of behaviors that we see most commonly in our individuals with CDLS, but you may have other behaviors as well, which we can certainly address if you have some questions about that. I'd like to move into talking about how do we assess these challenging behaviors. And as I mentioned, this part can take a long time. It may be something that is incorporating not only information from you as the parents, but you may also need to gather information from school staff or your in-home staff if you have in-home providers, or other caregivers who help take care of your child. So I always suggest regarding any behavior problem is let's first make sure there's not an underlying medical cause or a physiological problem that we need to address. So if your child might be in pain, we want to make sure that that pain or discomfort is being treated actively. With a child who might engage in pica, I always recommend to the families I work with is also let's get a blood panel done, because I've had a few instances of individuals with pica behavior who actually have a vitamin deficiency, maybe zinc or magnesium or things like that, which once we were able to treat that vitamin deficiency, the pica was eliminated. So that's really a helpful thing to keep in mind. So let's rule out those medical problems. So your primary care physician, or if you have a GI doctor who might be evaluating reflux or things like that, let's make sure that the pain aspect is taken care of before we move into developing a behavioral treatment. So once we've talked about those issues and made sure that we've done everything we can from the medical side of things, that's when we start to look at how do we conduct these assessments. And this is where someone like myself, I'm a clinical psychologist, or you may be working with a behavior specialist who might be a board certified behavior analyst, who use techniques such as those of applied behavior analysis. These are very specific types of strategies. It's an entire theoretical basis of assessment and treatment of any challenging behavior. It's not just discrete trial teaching where you're teaching academic skills, which might be something that some people are getting from in-home ABA providers, but the entire field of applied behavior analysis focuses on the use of behavioral principles that have been well documented to be effective in changing behaviors. So it's an empirically based assessment and treatment process, meaning we're very data-based. We love to take data on just about everything, but that's how we're able to demonstrate that it really is the types of treatments we choose that are the factors that are changing the behaviors that we see. So we use a lot of reinforcement strategies, which reinforcement is something that increases a behavior. And we also look at consequences in order to try and change the behavior that might be inappropriate or something that's not assisting the child in making further gains in their world. So we use applied behavior analysis techniques to increase communication skills, increase academic skills, increase social skills, but also to change challenging behaviors. ABA types of techniques can be used across a variety of diagnoses across all ages. So this can be done with kids that are really, really little. I've worked with a child as young as 10 months of age in our clinic. It can be used with someone very, very old. We've also had somebody, in their late 60s with a severe challenging behavior, severe self-injury that had been going on for years, but we were still able to make changes in that behavior. So it can go across the entire age range. We also can utilize applied behavior analysis techniques to look at different topographies. So hitting, kicking, biting, all of those different topographies that you can name, we can use these techniques to start to address and treat. And ABA can be applied in different settings. So it's not only going to be something that you can use these techniques in the home environment, but you can also use these techniques out in the community, in the school setting, at daycares, you name it, you can do it there. Some of the most key elements for applied behavior analysis are that it's a consistent approach. We're using different techniques that need to be implemented on a consistent basis by multiple providers with everyone who's involved with the child so that we know that the treatment is something that is working. It's objective because we're able to clearly define what the behavior is that we're looking at. We're able to clearly define the exact treatment components that we're using. That way, that if you were to say, we're using a treatment to increase their communication skills, we can exactly state what that communication strategy is that they're using, and we can take data on it. We can count the frequency of how many times it's happening. So it's very objective. It's systematically evaluated, meaning we can clearly look at data and graphs to demonstrate that the behavior change is happening, and it's happening in relationship to the type of intervention we're trying. You document the progress utilizing graphs. So if you have in-home ABA providers, they should be sharing it with you, the data that they're taking in graph format so that you can see the changes that are happening with your own child. ABA also utilizes techniques that are very well researched. A BCBA or a licensed psychologist using ABA techniques is going to be able to refer back to the different research studies that have demonstrated this has been effective with other individuals with similar behavior topographies or with behaviors that are maintained by the similar types of functions. And it can be adaptable to any particular learner. So it's not just for children with autism. ABA can be used with any diagnosis. It can be used with individuals who are very, very high functioning or lower functioning. It doesn't matter. We can modify the techniques to any particular individual. So I always joke that I can use ABA techniques with my husband if I wanted to change behaviors in him as well. Just like I could do similar techniques with any of the different clients I work with. So there's many strategies you can use. And their ABA strategies can be applied to different people. Additional components when we're looking at trying to evaluate and assess challenging behaviors are that we're going to do what we call a functional behavioral assessment. And if you have an ABA provider already, they may have used this terminology with you. And so this is when we're looking at trying to evaluate the causes or the underlying variables that are maintaining a behavior that's challenging in the environment. This is also something that can be done in the school setting. So a functional behavior assessment is required to be implemented in a school setting when a child has behaviors that are impacting the child's ability to make gains in their learning environment. So teachers and behavior specialists would be conducting what's called a functional behavior assessment, or an FBA. They then use that information to develop a behavior intervention plan. To start a functional behavior assessment, the team would start by conducting some interviews. So the in-home ABA therapist may talk to you about the different situations that are challenging for your child. Under what situations do you always see this behavior happen, for example? When do you never see this behavior happen? Those are always two questions that I ask right from the get-go with families, because those can tell me some very important things. In the situations where this behavior always happens, what are the key factors in those situations that are challenging for this individual to understand or to deal with? But when the behavior doesn't happen, leads me to a lot of information about what is reinforcing for that child. And we're going to talk about reinforcement a little bit later. So there's indirect interviews. There's also some indirect questionnaires. So you may have completed a functional assessment scale. There's many different questionnaires that are out there. There's something called the FAST, which is functional assessment screening tool, or there's a QABF, questions about behavior function. Those are just two common ones, but there's many different questionnaires that could be given to give some hypotheses that may tell us what maintains this problem behavior. So once we've gathered some indirect information, we also try to collect direct observation. The most common form of direct observation is going to be by having ABC data collected. ABC data is antecedent behavior consequence data. That is antecedent, that's what happened right before the behavior occurred. Behavior, exactly what behavior was elicited. And the last part, the consequences, what happened immediately following that behavior. So if the behavior was a tantrum, and let's just say that tantrum happened in the Target store, I would ask you to say, okay, well, tell me what that behavior was. Oh, well, they fell to the floor and they hit me 4 times, they pulled my hair and they screamed. Okay, how long did it last? Give me a rough idea. Antecedent, what was happening right before the behavior occurred in Target? And that might be, hey, we were shopping for 30 minutes and we ended up in the shoe section. And that might tell me a little bit more about what the situation was that's going on. And then consequences would be, what did I do right after? As a parent or as the observer, what happened right after that behavior occurred? Oh, well, we left the store. I just left that area. So that ABC of that tantrum tells me a lot of information about what might be maintaining the behavior, as well as what might have led up to that behavior. So if I'm the therapist working with you, I'd like to collect ABC data across many different days, many different situations, so we can get a lot of hypotheses drawn from the data that you've collected for us. Oftentimes, this level of assessment is enough. Doing the indirect and the direct observation is enough to come up with some good ideas for treatment intervention. However, for some individuals, that isn't sufficient. We need more information because this is a behavior that's very challenging, and we need to get more precise and specific about the functions. And this is when a functional analysis might need to be implemented. And this usually would be done under the direction of a licensed psychologist or a board-certified behavior analyst, where they are going to manipulate different variables in the environment to see what the effects are on behavior. What do I mean by that? I mean that in a direct observation, the therapist might actually provide specific consequences across different conditions with your child. These conditions would include a toy play. A toy play is our control condition, meaning we would expect very low rates of problem behavior in that situation. Most typically, what's going to happen there is the child has access to preferred items that they like to play with. They get access to attention at least every 30 seconds. And so they should be pretty happy. No demands are being placed. And this is what we use to compare the other conditions to see if behaviors are happening in the other types of situations. Another condition that we evaluate in the functional analysis is a demand condition where academic or home types of demands might be placed. The home demands being maybe adaptive daily living skills such as brushing teeth, brushing hair, setting the table, putting on shoes. So we might evaluate those types of demands being placed in this demand condition, and we might say only during this assessment part that when the child has a behavior in the demand condition, they get to escape the demand. This is not what I want you to do in your home environment, but for this particular assessment, it is just to look at, is escape from demands maintaining this behavior? So in the demand context, a demand is placed, child has a behavior, we say, okay, you don't have to do it, and they get a 30-second break. And then we go back to demands right after that 30 seconds. If there were lots of behaviors in that demand context, we would then know that it's very likely that the function of the child's behavior is to escape demands. So that's one comparison to the toy play. Another situation is what we call access to attention. And in the attention condition, we're evaluating, is it getting attention for the problem behavior that's what's maintaining this behavior or keeping it going? So in that session, we would evaluate if the child has a behavior, we would give attention. Oh, don't do that, you're going to hurt yourself, or don't do that, you're going to hurt me. Only within this context so that we can compare the data from that attention session to the toy play to see if you have higher rates of behavior in that attention condition. If you have higher rates in that attention condition, that would then suggest that behavior is maintained by access to attention. Regardless of whether it was positive attention or negative attention, they had more behaviors in that context to gain access to any form of attention. So we have a control condition, escape from demands, access to attention. The next one would be access to tangible items. Does the child engage in behaviors to gain access to a preferred item back or access to an activity back? So if you take away their iPad, do they have a behavior in order for you to return it to them? And then the last type of condition might be an alone condition where we're evaluating whether or not the child engages in behaviors to gain access to sensory input. So if a child has a lot of self-injurious behaviors when they're left alone and there's nobody providing any attention, there's no demands being placed, we would anticipate that that behavior is maintained by what we call automatic reinforcement or something internally driven. So that's a functional analysis. So why do I say that function is so important? What do we think about this? So it's important for us to get a clear understanding of the function so that we know the right path to take for intervention. If we don't know what's happening, we may inadvertently make a mistake and provide the wrong treatment. So for example, yelling or telling the child, no, don't do that, could make the behavior worse when the child's behavior is, sorry, my lights go off automatically, I have to move. I forgot about that. Yelling could make the behavior worse if the child is engaging in that behavior to get your attention. So telling them no may actually be the opposite thing that we need to do. Another example is timeout. If the child's engaging in a behavior to escape demands, giving them a timeout for their behavior is only going to increase the behavior happening. So when we're doing our behavioral assessments and we're trying to figure out this function, we're going to start by making sure we all can agree on what that behavior is and how to define that behavior. And then we're going to take data on it. So this is part of that functional assessment as I've described already, but here are some of the slides that go along with that. I got ahead of myself, sorry. And the functional assessment is to help us define and identify those variables that keep that behavior going and develop the hypotheses about the functions of behavior. The most common functions are the ones I've just talked about: access to attention, access to tangible items, escaping demands, escaping non-preferred activities, or automatic reinforcement. Now, how does this relate to different functions in children with Cornelia de Lange syndrome? And we've conducted several studies, and Oliver and colleagues also have conducted similar studies to look at the association between the environment and problem behaviors. And we have found that the functions of behaviors in individuals with CDLS does not differ from the functions that we see in a broader population of individuals who also have intellectual disabilities. So basically, individuals with CDLS are not more or less likely to have behaviors associated with the environment than those without the syndrome. So it tells us that we are able to identify functions even with individuals with CDLS. The diagnosis itself doesn't make the functions of behavior change or different. So this is a really good time to take some questions about the assessment process, and if you have any questions on this particular area before we move into specific treatments.
Great, thank you, Julia. Our first question is it normal for kids only to act out towards their parents? We have talked with the preschool that our daughter attends and they see no behavior issues.
This is quite common, and that's across typically developing children as well as individuals with CDLS. Actually, I just read a recent study that came out, and it says that even more specifically that children in general have more problem behaviors with their moms than with anybody else. Why is that? Probably because they're with moms mostly. Also, the mom is the one doing most of those caregiving types of tasks. The mom is the one presenting demands. The mom is the one making them do the things that they have to do. And they love mom's attention. She is somebody that they value highly. So it's very, very common that it's more likely to happen with a caregiver, but specifically with mom. And I deal with that quite often, especially with schools. And families talking to their schools about why, you have no behaviors. How can that be? I have all these behaviors. It's a very different environment and different structure. So it's very common.
Great, thank you. Next question. You listed age as a risk factor for SIB. Can you elaborate a little further?
So it's associated with as individuals do get older, you may see self-injury, and you may see self-injury at different times. I mentioned that puberty might be a time that you start to see the behavior, but it doesn't differentially matter if their diagnosis is CDLS or some other disorder. So you may see it more often at specific ages, but not necessarily just because of the diagnosis of CDLS. But generally speaking, you see it happen not necessarily when they're very, very young, but as they're school age and older. And that may be correlated more with the difference in still not gaining more and more communication skills.
Great, thanks. And this is going to be our last one for this segment. How important for parents and school personnel to follow the plan for behavioral challenges?
It's very important. If the behavior plan is developed and not followed, the behaviors are not going to change. So if you would like to see behavior change, then implementing the behavior plan as consistently as possible is going to be required.
Okay. Great, thanks, Julia.
Thank you. Okay, so now we're going to move on to treatment. And with treatment, I have a couple of things there we go. Different treatment options that are most common. Medication trials, protective equipment, behavior treatments, and then any combination. Excuse me. Regarding medication trials, just going to say very briefly, there has not been one medication that has been identified to change self-injurious behavior in general or within the population of individuals with CDLS. There's not a single medication that's been identified. So what does that mean? It's going to mean that you want to consult with a psychiatrist who has experience with CDLS and consult with them to discuss what medication trial might be warranted. Most typically, you're going to do a medication trial in conjunction with developing a behavioral treatment. Many of our individuals with CDLS also have a concomitant psychiatric diagnosis, maybe ADHD, maybe bipolar disorder, maybe anxiety. There may be medications to target specific symptoms in which case the psychiatrist is going to know the best which type of medication that is to address specific symptoms, while a behavior psychologist working in conjunction with them can monitor the effects on the behaviors. And that's one of the things that we do very consistently in our clinic, is work together with the psychiatrist to do that. Protective equipment is one I actually don't have a slide on, but protective equipment is something I use in conjunction with the other behavioral treatments, especially when there's any tissue damage or head-directed self-injury, whether it's head banging or head hitting. We would want to have a helmet to protect just in case, and also look at being able to fade the any type of protective equipment that's required. That's specific protective equipment for the child to wear or the adult or individual to wear. Sometimes if it's aggressive behavior, I do have parents who might wear, say, arm guards or protective sleeves if there's, say, scratching that's happening a lot, to keep you safe as well. So moving on to other types of treatments and looking at behavioral treatments. Overall, the goals for behavioral treatments are to increase the appropriate behavior while also reinforcing when the problem behaviors are not happening. We also want to make sure we're increasing the amount of reinforcement in the individual's environment. We might need to also improve academic performance if it's a problem at school, as well as we mentioned reducing the challenging behaviors. Now, as I mentioned from the beginning, treatment strategy depends on the function of behavior. And we always try to start only by implementing one strategy at a time, so we know if that treatment is effective and still needs to continue. What I typically do is if we see a reduction in the behavior, but that reduction is not to the point where we all agree that this is improved, then we can add additional components until we get to a point where we're all in agreement that the behavior has been reduced enough. And if we see that the treatment's not working, it's time to change the strategy. If it didn't help at all, let's change that and move on to some other treatment component. So first I'll talk any new or mild behavior problems. So a problem that's not currently causing any damage to self or others, a problem that's really mild but kind of annoying, because there's a lot of those annoying kind of behaviors. What I always start off with is thinking about, well, yeah, let's try to add some additional, very stimulating activities to the individual's schedule so that we can rule out that boredom is a factor, or rule out that, you know what, you're kind of tired of these reinforcers we've been using. And we also want to look at, with these new behaviors or mild behaviors, how is it that the caregivers are responding to that behavior? And let's make a change at that level first, because it might be how we're responding that's helping to keep that behavior ongoing. Inadvertently, we're not trying to make it keep going, but inadvertently it happens. So we want to make a change there. And then I'm going to start off with conducting what I call a preference assessment to identify potential reinforcers. Reinforcers are something that increase behavior. So they can increase an appropriate behavior or they can increase an inappropriate behavior. That's why it's so important to know what is reinforcing the challenging behavior so we can eliminate that reinforcement while reinforcing a more appropriate alternative behavior. So we conduct preference assessments. This might be started by having an interview with the parent or interview with the teachers about what are some of the child's most preferred items. And I always make sure that I'm looking at those items across all sensory modalities. So I'm going to look at items that are visually stimulating that the child really enjoys, auditory, do they really like a certain type of music or a particular sound, things they like to touch, tactile. So I have a recent child who really likes to touch things that are warm. So when we go out on walks here in our clinic setting, he always likes to touch the different animals that are outside, that are statues of animals that we have outside our clinic that are really toasty warm when it's nice and sunny, or touch the roof of cars because they're nice and hot. So tactile stimulation, auditory stimulation, visual stimulation, olfactory, maybe there are particular smells your child likes, and then also vestibular, perhaps they like swinging or other types of vestibular like the trampolines and things like that. So let's find potential reinforcers for them and conduct what we call a preference assessment. Typically, I just do a paired choice assessment. What I mean by that is I take 2 items, I present them, whichever one they pick is the chosen item, and I usually do that across 6 to 8 different items until I have a hierarchy of the most preferred items. And this is just a sample graph that I had with one of the kids I worked with. They preferred watching TV over listening to an audio tape at the time. This is an old slide, but over like a DVD. So we ranked them and we have a hierarchy. So this gives me a few different items that I can use to increase appropriate behaviors that I want to. And it's important to have that idea of what those items are. I always make sure I evaluate tangible or physical objects separate from edible items. And it's also important to really get a hierarchy of what those edible items might be, because not every child prefers the same edibles. I see this as a challenge in school settings because oftentimes if they're using edibles, I see them use the same edible item with all the kids. Well, maybe not everybody likes goldfish, so I should do a preference assessment for that particular child to make sure I know what edibles are most reinforcing. So once I know what potential reinforcers the student has, I can utilize those to then start working on different treatment options. These are all strategies that I've used across different children with various behavior problems that have been more what I call preventative strategies, teaching them a social story about the activity or the event that might be disruptive to them, teaching them coping skills such as deep breathing or relaxation, using squeeze balls, listening to music. Also adding in a structured schedule. Many of the kids that we work with, and it's often the case that children with CDLS and adults with CDLS really like to have structured schedules. And so adding that in proactively is something that I try to do to see if that will help minimize some of the situations that are most challenging. And if there's any of these particular treatment strategies that you would like to have more information on and we don't get to talk about that today, please feel free to reach out to the foundation because they can connect me with you and we can talk about how these might be able to be incorporated. Other options to utilize when we have challenging behaviors are going to be redirection. So the behavior happens, but without commenting on it, we suggest something else to do. So your child threw a ball, well, not a ball, but say threw a toy at another child, just gently move them to a different activity to take, oh, let's go play with this instead. So redirection like that. Or praise the individual as soon as they start engaging in a behavior other than that inappropriate one. These differential reinforcement strategies are different scheduled attention types of interventions that we use for children who have behaviors that might be maintained by access to attention. Differential reinforcement of alternative behavior is reinforcing the communication response they use instead of saying anything about the challenging behavior. So if we taught the child to say, hey, I want to play with you now, or mom, play with me, reinforce that and ignore any time the challenging behavior were to occur. Differential reinforcement of incompatible behavior means we're shaping or we're reinforcing a behavior that is not compatible with the topography that we're trying to change. So if your child has hand biting as a topography that they engage in, let's reinforce them for putting their hands in their lap or folding their hands and saying, great job folding your hands, because they can't fold their hands and pick at their or bite their finger at the same time if you're reinforcing folding your hands on the table. Differential reinforcement of other behaviors means reinforcing every other behavior except for that inappropriate behavior that you're trying to decrease. So if it's, say, screaming and they scream all the time, you want to have them decrease, we're going to have a DRO, or differential reinforcement of other behavior, whereby if they haven't had any screaming behavior for a certain length of time, we're going to give them the reinforcer. Maybe it's praise or maybe it's an edible, but it's great job, you're using your nice voice. And that's a really other important component, is not to talk about the negative behavior, but focus on an appropriate behavior that's replacing that inappropriate one. So rather than say, oh, nice job not yelling, say, nice job keeping your voice down. The last type of attention, scheduled attention, would be what we call non-contingent attention. And that's just every so often on a fixed schedule, providing attention regardless of what behaviors are happening. So maybe it's every 10 minutes, making sure we say, hey, I really like the way you're playing nicely. And that's really just a way to increase how much positive attention they're getting throughout the course of their day. Then we also look at teaching replacement behaviors. So I mentioned earlier about teaching communication skills. So this might be where we're teaching the child to use a functional response. This could be a verbal response, or it could be a voice output device, or it could be handing over a card to ask for attention or to ask for a break from work. So for a child who has behaviors maintained by escape from demands, instead of allowing escape to happen, is you would teach them to hand over a break card or ask for a break instead of engaging in a problem behavior to get the break. Usually with that, we teach it so that every instance of the break request is honored, but once they've learned the skill, then the break is only honored after having completed a certain amount of work. So after 2 demands, then they can request a break, or after 5 minutes of working, then they can request a break. Teaching replacement behavior may also be teaching leisure skills. Oftentimes our children have a really hard time developing leisure skills, so we may need to start working on teaching those very specific toy play or leisure activities. The other strategies that we use when we're working with our students or our children is to learn about how to provide prompts and how to follow through on prompts. This is especially important with behaviors that are maintained by access to escape from demands. It's always important that if you're going to place a request on your child to do something such as brush your teeth, then you follow through. What I tell families is, if you don't think you can follow through on the demand, then don't bother asking, because I want the child to learn that anytime a demand is being placed, that you are going to make sure they follow through on that. And once they've completed that, and that might take some hand-over-hand guidance, reinforce the compliance with that behavior, and then gradually you're able to fade out your prompts once the individual has learned that prompting is always going to take place. And this takes a lot of practice. So it takes repeated practice to learn how to use these types of skills, especially across different people and different settings. Another key component to behavior plans is often something we call extinction. And this is not providing the desired consequence for the behavior, or doing the opposite of what the child is trying to gain. So for example, if your child is trying to get a reaction from you, they want to get you to say, don't do that, or they want to get you to yell or get upset. Instead, and I know this sounds really easy and it's the hardest thing in the world, we suggest not attending, but ignore the behavior, or block the behavior and ignore the behavior. You do not have to tolerate your child just hitting you. You can block it, you can walk away, but what I'm suggesting is prevent the reaction that they're looking for. Prevent that burst from continuing by walking away, making sure they're safe, but walking away, or just not saying anything. If your child's trying to get out of doing something, so they're trying to escape the demand, you'd ignore the behavior, ignore that tantrum, and keep going with whatever that activity was that was on the schedule, or whatever that demand was. Always follow through on the demand that was given, so they learn that you mean business. You mean that when you say to them, hey, it's time to do X, they're going to need to do X, even if it's something that you physically guide them to do. Another example, the child wants something they can't have, and this happens quite often. They want to have your iPhone, and you're like, you can't have my iPhone. So typically what I would suggest is tell them no and ignore the behavior, and redirect them to get busy doing something different. Provide some other activity that they can do at that time. And finally, if the child seems to be doing it to get some type of self-stimulation, what I suggest is keeping them busy and try to block that self-stimulatory behavior, or that behavior that might be automatically maintained, and look for an alternative way to get that similar stimulation that won't cause any injury. As I mentioned earlier, always try to treat any medical or physiological condition beforehand and address those particular types of discomforts. We might also provide alternative forms of reinforcement. So if you have a child who engages in self-injurious behavior, that they seem to really enjoy the sensory input, let's see what other type of activity can provide similar input and block and ignore that behavior. Again, it's really important to teach maybe leisure skills or play skills so that they can get reinforcement for something else instead of the inappropriate behavior. Sensory extinction is the process by which we don't allow the sensory input, and this often involves use of protective equipment to prevent that internal input from being accessed. So some of the strategies I've mentioned about behaviors, and this is going to focus specifically on just attention maintained behaviors, strategies we've talked about, but putting it in the context of just attention, teaching a functional communication response. Play with me, please. I want attention, please. Or using something like a picture exchange communication system. We also talked about differential reinforcement of other behavior. So providing attention contingent on no problem behavior occurring, or offering attention for the specific communication response. Behavior that's maintained by access to items. So they really want to have that iPhone of yours, state no once, continue with another activity, or provide no comment or attention. Teach the child to ask for more. Teach them another way to request access to the preferred item that they're looking for. This also might be a time where you use a picture schedule where that item is available only at specific times a day, and you can redirect them back to that schedule to show them, okay, the iPhone or the iPad is available at this time, and that's when you'll be able to get it. For escape maintained behaviors, these are those behaviors that are maintained by trying to get out of doing their work. You want to prompt them through that sequence and make sure you complete that demand with them. It may be challenging sometimes to complete the demand. You may have to wait for them to be calm first and then make sure you go back to that demand and complete it with them. This is also a time to teach them that request for break or help so that they learn they can earn a break and they can earn access to reinforcers. This may be where a token system could come into place, where they complete one demand, they get a token, complete two demands, get a token. They trade their token board in when there's 5 filled, and they get a bigger reinforcer for having earned so many tokens. It may be that with certain demands, you have to teach the child the specific steps by breaking the demand into smaller steps so that they can accomplish that task. Now moving on to those behaviors at school. Behaviors that happen at school are ones that we want to make sure that the school is starting to conduct that functional behavior assessment. This is something that's required by IDEA. It's mandated by federal law. So anytime there is a behavior that's happening in the school setting that is impacting your students' ability to learn in that environment, they are required to conduct a functional behavior assessment. And you should ask that of the IEP chair. Once that functional behavior assessment is done, then they need to develop the behavior intervention plan to address the behavior and have a specific plan of action in place to train everyone at school to implement that plan. The FBA and BIP should be reviewed on an annual basis and modified when that plan is not changing the behavior like you expect. The behavior plan should have both behaviors to increase as well as decrease, because you can't just decrease behavior in the absence of reinforcing a more appropriate behavior, because you need to maintain a certain level of reinforcement, and the only way to do that is to increase in a more appropriate skill and give the reinforcement for that. The BIP also has to evaluate the type of data collection system and be reviewed on a consistent basis, usually quarterly, if not more often. This is a really important fact that in functional behavior assessments at school and the BIPs, parents and teachers should work jointly and collaboratively on these plans. Your input is invaluable to them. You know your child very, very well. You know the types of things they enjoy and like. So it's really helpful to know that if there's some strategies at home that are working, school could incorporate, and vice versa. If there's a strategy working at school, maybe you can incorporate that into your home environment. And it's also helpful that there's consistency across the two settings. So having the same types of strategies in place across both would be ideal. So in conclusion, we need to develop a good assessment of the behaviors in order to determine the function, because once we have the function of the behavior, we can develop some replacement behaviors to reinforce, and then we implement the plan consistently. And we need to take data on that so that we know that the plan is working. And be persistent with this, because we have been able to show that it's very possible to change behavior by increasing the appropriate skills and decreasing challenging behaviors in individuals with CDLS. And you just have to be very persistent with that. And it may take time, and you may need to change things over time as you're evaluating the effectiveness of your behavior plans. So that leads us to round 2 of questions.
All right, thank you so much, Julia. Our first question, how do we treat automatic behaviors?
So for behaviors that are maintained by automatic reinforcement, oftentimes if the behavior is causing any tissue damage, we are going to want to have some protective equipment for that. If it's not causing any tissue damage, then automatically maintained behaviors, we're going to try to find a behavior or a activity that could give similar sensory input, but that's safe to use and not necessarily something that's keeping them from being able to engage in the school activities or home activities. We also may try to use the self-stimulatory behavior if it's not causing any damage, use it as a reinforcer at a time when it's okay for them to engage in. For example, if there's a lot of automatically hand flapping, for example, we may teach them not to engage in it during social activities with peers, but maybe it's okay that they are able to engage in the hand flapping in the privacy of their own room and still get that sensory input. So it depends on the type of behavior it is, exactly how we're going to move forward with the automatically maintained behavior.
Great, thank you. Next question. Can the causes of select mutism be treated through ABA?
Yes, they can. Absolutely. And it's funny you bring that question up, because as we were talking, I got a text from one of my staff. We just treated a young lady, she's a middle school age girl, for selective mutism, and she got her report card, and she made tremendous gains in all of her grades because she was now able to participate in class because of the treatments that we did with her here. That's a challenging behavior, but it definitely can be treated with ABA, and I'd be happy to talk more specifically about the specific strategies that we've been successful with here.
Great, thanks. The next question. The solutions you mentioned work well at school, where they have dedicated paraprofessionals every minute for their school day, but that level of care isn't always practical at home. How do we balance that?
And that's absolutely the case. So I've worked with families, you know, my primary place that I try to help families is with the home environment. Because as you say, schools have so many more staff members. They have more people that can do this. Sorry, I haven't moved enough. My lights are going out. Okay. So we make a point of implementing the behavior plan not only in the clinic setting, but taking it out to the home and working with families to adjust the level of the plan and the level of one-to-one that's needed to implement the plan. So we always try to develop a reinforcement component that can be implemented with as much ease as possible in the home environment. So it's a matter of modifying the treatment plan to be able to be used with the staffing you have in the home, which is usually just a mom or a mom and a dad, but maybe 2 or 3 kids. And how do we put that into place? And a lot of times it's taking the schedule that we developed in the clinic, if the schedule is a part of it, and incorporating all 3 of the kids as part of the schedule. So everybody gets a little bit of mom time, a little bit of dad time, a little bit of this activity, but it's a matter of modifying it so that it can be something that can be utilized in the house. Again, we probably have to talk more specifically about your particular home environment and how we could arrange it that way.
Great, thank you. And last question. Where can we get helmets and arm guards?
Okay, so the helmets that we typically purchase are through different karate types of websites. So a lot of times they're called macho helmets. They're padded helmets. There have been occasions when we've been able to get insurance companies to pay for them under durable medical goods if your insurance carrier has that as a reimbursable expense. That typically would require a medical professional to write a prescription for the helmet, and then the insurance company would reimburse you for that cost. So I'm going to tell you they're typically macho helmets, which also can have face masks added if that's required. And I think you mentioned arm guards. Arm guards, the ones we typically use are the ones for martial arts. So if you ever know anybody who does martial arts and they do sparring, they often have pads on their arms. So those are the types that we typically use. The other types of arm guards that I use have been Kevlar sleeves. So they're much thinner than the really big puffy padded arm guards. But their Kevlar is like what they use to make like bulletproof vests and things. So even though a lot of times Kevlar sleeves are put on either the child who bites or if the child bites others on that person. So you might see the indentation or a bruise, but you don't get the broken skin. So Kevlar sleeves are good for that too.
Great. Thank you so much, Julia, for taking the time to answer those questions. We do have quite a few unanswered, so please, we definitely encourage you to submit your question through the Ask the Expert form that can be found on our website by choosing the webinar. In the drop-down, we'll make sure to address all of your questions individually. So thanks again, Julia, and back to you, Lynn.
I would like to thank Julia for taking time from her busy schedule to provide such important information to the CDLS community. And many thanks to all of you for joining us today. We would appreciate if you can take a few moments to complete the survey you will soon receive to provide us with your feedback. See you next time.